Everybody, thanks very much for being here. I'm Jim Sturgis, Executive Director of Pioneer Institute, and welcome to all of you to the 2022 Hewitt Healthcare Lecture. I'm going to give you a quote about how I feel about today. This is from Mark Twain. The calamity that comes is never the one that we prepared ourselves for. That kind of feels like how life is these days. The world has really gotten weird. As we came in, the sun was out. There was no wind. And earlier today, our speaker, he's not here. He'll be up here in just a minute. He wasn't able to make it because he was stuck on the tarmac in Washington, D.C. for 4 hours. At 4:30, we decided to pull the plug, have him go back to his office. Bill Smith's going to interview him from here. We'll get the same content, even better quality. You see all the stubble on him on that giant screen. It's fantastic. But first thing I want to say is to my staff and to the staff of HMS, thank you very much, guys. You all got everything squared away really quickly, nimble, and got problems solved really quickly. So let me just start with a couple of things, if I could. First and foremost, thanks to the Hewitt family. I really appreciate your continued support of this effort. To the extended family, everyone in the family, John, Josie, thank you for all that you do. Colby Hewitt Jr., Chuck's dad, was a huge presence at Pioneer Institute, and this lecture is named in his honor. He was the chairman of Pioneer for about 8.5 years, right up until he died. Literally the week before he died, he was holding a board meeting. Elegant guy, someone who's super smart, committed to issues. The issue he's most committed to was healthcare, transparent healthcare, effective healthcare, affordable healthcare. He was as committed to that as he was to Pioneer Institute. Something was deep in his heart. And we like to remember him every year with a lecture about issues that are related to, this one's more broadly healthcare related, the fentanyl crisis. It is a huge issue for hospitals. It is a huge issue for civil society. It's a huge issue for all of us as a society as we see this really spiral out of control. A couple of comments on Pioneer the last couple of years, the work that we've done outside of this lecture. And this lecture is sort of a fundamental piece, a touchstone for us in the work that we do on healthcare. The last couple of years, you remember there was this thing called COVID, right? And we focused an awful lot on that in terms of transparency, dealing with the government, pushing back on the government where they overreached, supporting the government where they were actually following reason, and trying to find solutions as always. Some of the things that we pushed were things like telehealth, and trying to make sure that we could actually provide that as broadly as we could, allowing new sources of supply, scope of practice, and allowing for nurses who were trained up to a certain level to actually practice at that level, making sure we could provide services at a time when things are really constrained. Over the last year, we have made a really strong move, a lot of energy behind our life sciences initiative. And our twin goals there are really to make sure that people can get access to therapies and to preserve and promote the development of life-saving therapies. I don't think it's any secret to anyone that over the last 50 years, if you take a look at the number of hospital beds that we had, they went from about 1.6 million to about 800,000. That is a march of the market. However much we might want to argue about government's role in healthcare or not, the market is sorting itself, and life sciences are becoming more and more important in this realm of the future of healthcare, whether personalized medicine, therapies that are actually cures, outpatient care that's fortified with new solutions to healthcare problems. Bill Smith, he's the head of that life science initiative. He'll be up here in just a minute. This year, the initiative really took off. We built out our team. Robert Popovian, who's a wonderful, talented economist and pharmacist. He joined our team, and we have a number of other folks who are working with us from around the country on issues related to how do we make sure that these drugs are affordable enough to get into people's hands? How do we make sure that we promote the development of life-saving solutions? Currently, about a dozen think tanks are following our work in the life sciences. This is something that Bill's been building. And just this past week, we secured a commitment from a national organization that will help us to get in front of even more think tanks and do our work providing expertise they don't have. But tonight, we are here to talk about the fentanyl crisis. It's an epidemic. It's one of the most pressing issues that's facing our state, our nation, our hospitals, and the social fabric. Fentanyl's inexpensive. Fentanyl's easy to replicate. It's deep in our criminal networks. This past year, it's estimated that 108,000 Americans lost their lives to fentanyl. It's rising. It's rising fast. If we're Massachusetts, it's especially dire here. We are among the states in New England with the highest rates. Seizures of fentanyl are super high in Massachusetts. And I can't tell you how excited I am to have John Walters here to speak with Bill about the issue, because John is one of the premier experts in the country. I'm not going to introduce him. Bill's going to introduce him, but just very briefly, what I'd say about him is he is capable of looking squarely at the issue, describing it in a comprehensive yet concise way, to share what he thinks solutions may be. He's tough-minded. He can take tough questions. This is a must-have conversation, and I'm really honored to have John Walters as our 2022 lecturer. Bill, if you don't mind coming to the podium, I'd really appreciate it.
Thank you, Jim. So in a preliminary way, let me say that if my interaction with John Walters seems a little bit like he's the professor and I'm the student, that's because he was my boss in the White House. And you're in for a treat tonight, because I don't think, this is not hyperbole to say this, but I do not think there's any living American that knows more about US policies towards illegal drugs than John Walters. Serving two presidents at a very high level, George W. Bush, he served in the cabinet. And so I think you're in for a treat. John is also, he was a great boss. Let me just say, he's one of those people that is not ideological or rigid. He's willing to change his mind. He looks at policy questions and rolls them over and tries to find the best solution. So hopefully you'll see that in his talk tonight. Just by way of introduction, he's currently the president and CEO of the Hudson Institute, which is a very reputable think tank in Washington. From 2001 to 2009, he was the director of the White House Office of National Drug Control Policy, which is a cabinet level position. And that was during the George W. Bush administration. And as the nation's quote unquote drug czar, that's the informal title for his office, he guided all of federal drug policy and programs, supporting efforts that drove down teen drug use by 25%, increased substance abuse treatment and screening in the healthcare system, and dramatically dropped the availability of cocaine and methamphetamine in the US. Prior to that, John served as president of the Philanthropy Roundtable. His prior government services included work at the Office of National Drug Control Policy under President George H.W. Bush, which is when I worked for him. He was assistant to the secretary and chief of staff at the U.S. Department of Education during the Reagan administration, and earlier he was at the National Endowment for the Humanities. He has a BA from Michigan State and an MA from the University of Toronto. So with that, I'm very excited and honored to introduce him. And John, you can take it away now.
Well, thank you, Bill. I want to thank both you and Jim for your kind words. It's good to be with you. It would be better to be with you live. This is less than satisfying for you, and I assure you, for me, I also hope to be able to spend some time in Boston with Jim and Bill and some others talking about your work on policy, because we have a lot of things in common. Thank you for inviting me, and I apologize that the weather and sometimes the less than stellar performance by our infrastructure and the airlines didn't allow me to get there. But let me address the issue, because I think that's what you're here for, and it's an important issue. The question of why we have this problem, I would say in the simplest terms, has a kind of three-part answer. The first is deep confusion, some misguided views and some dogmatically held misguided views about the nature of substance abuse, which create difficulty in coping with it. The second is bad policy arising from some of those wrong-headed dogmatic views. And the third is a principal adversary of the United States, the People's Republic of China, that is using the two first causes, bad policy and confusion, to harm the United States semi-directly and through criminal proxies. So this is a problem that has a kind of coming together of parts in a way that is particularly dangerous with this substance. Let me say a couple things about the parts, and then I want to leave time to answer your questions and not just talk at you, especially since I'm now a virtual person and not a real person. The founder of Hudson Institute, where I now work, Herman Kahn, was once interviewed about a book he wrote about trends in the future, and he was asked by the interviewer, why are you so optimistic about America's ability to cope with threats in the future? And he told the interviewer, I'm not optimistic, I'm realistic. The problem is most other people who talk about this have no idea what they're talking about. And I think that's certainly true of drug policy today. And I think, frankly, I myself have learned more over time thinking about it and seeing some of these things evolve. I think there's other areas of policy that we need to rethink as well. And I know you're doing that in healthcare and other areas, but I think that policy analysis is now urgent. Look, most of us have experience with substance abuse, and that is a starting point. We know somebody, a friend, a family member who has problems with alcohol, with illegal drugs, has had them. We've known people, I think most families, people who've died. I think we need to learn a little bit from that. It's painful, so we try to look the other way. But the fact of the matter is, we know that these substances change human beings, not to be too scientific here, but it changed the way our brains work. They change the way our ability to be independent, to think, to be free in our own lives. When mom's drinking at Thanksgiving this year, she's going to be a different person. When your son or your uncle is there and they're using, they become a different person than what they were. We do have people who are, and many of them who are in recovery, but we know that when they're under the influence of these substances, it fundamentally can change the human person. They can be changed to the point where they'll seek, their life collapses into seeking and using these substances, even to the point where they, with some awareness, are killing themselves and know it. We forget that when we have a bit of confusion at the starting point, when we think in some cases that the use of these substances is like other choices and it should be part of the pursuit of happiness in America. That pursuit was based on people still being independent, free individuals and not have their free will taken over, and their judgment and their ability to act as a family member or fellow citizen and neighbor is hijacked by these substances. We have a great deal of problem, I think, properly appreciating that and seeing what it does, despite our experience with people in our own lives. And that's been one reason for confusion. The other is, I think, that we have watched an evolution of these kinds of substances that people can abuse. Alcohol, of course, over long period history of the United States, but other drugs that are controlled, heroin, other opioids like fentanyl, cocaine, methamphetamine, marijuana. And we have failed to see that they have now fused together into a phenomenon of polydrug use that you see more and more, even though this has become undeniable. I mean, Boston is like other cities where you have people slowly dying on the streets, living in tents, laying out in the parks. It's gotten so in most cities, we've become so callous, we just walk over people and let them lay and die. We don't think of substance abuse the way we have been able to understand it as a disease, a behavioral disease, a disease that's not like a pathogen like the coronavirus that is external, but one that we become exposed to, and that these substances begin to distort our ability to live our lives in fundamental ways. In fact, they also create a kind of desire now with so-called polydrug use of multiple drugs, of using a variety of them in combination over time to just be high more and more of the time, or when any kind of unpleasantness in life occurs. So we've seen this on a wide scale, and we've let it become wider. We've now, most states have in some form or another decriminalized. We've legalized the sale of marijuana in various forms under the guise of medicine or other things, despite the science and research showing increasingly the danger of marijuana in particular, but these other substances in general. Fentanyl specifically, which your topic is tonight, has grown out of that wider form of use. And I think the other part of this that changed from when Bill and I were in government is what we sought to do is control the supply of drugs where it was being made or transported, and on the other side, control demand through prevention and treatment. We changed policy during the Obama administration. The Obama administration proudly announced that it was going to end the drug war, by which it meant it was going to stop supply control. It was going to stop focusing on interdiction and enforcement in the United States, and focusing on the supply control from sources outside our country. And it was going to focus on treatment and prevention. So we have an actual policy experiment. When I left government, teenage drug use had dropped 25%, and had been dropping over a period of time, with some blips up and down, with some different substances coming on the scene, but it was generally improving. Even the synthetic opioid prescription medications that had become widely abused in the 90s, and methamphetamine from small toxic labs. But the Obama administration changed policy on the grounds that the harmful effects of enforcement outweighed the benefits, and that you could do better by decriminalizing in some cases, and certainly is putting more emphasis on treatment through Obamacare and prevention. So we've had an actual, what social scientists call natural experiment. I think it's pretty clear that natural experiment has failed. Look at our cities, look at the overdose deaths at historic levels. And the other fact here is that during the Obama administration and subsequently, we unwound a bunch of the things we used to do to measure the extent of substance abuse. We don't now have data that's reliable about self-reported use, because COVID intervened and such self-reported surveys were curtailed for various reasons. Secondly, there was a shutdown of the system of looking at admissions to hospital emergency rooms related to substance abuse and by drug. There was an elimination of a program that tested some sample arrestees for substance abuse in relation to the commission of crime. We used to have surveys that looked at admissions to treatment in various ways. Those also were shut down. So now we have a problem that we are not even seriously looking at. So if we were going to have a change in policy and it was going to work better, it's a little it's impossible now to measure that, because there is no baseline and there's no measurements taken. I mean, that shows you a measure, I think, in how seriously we've lost responsibility, our sense of responsibility for this problem. Finally, in regard to fentanyl specifically, of course, as was mentioned earlier, it's expensive and it's concentrated. There are so-called analogs of fentanyl. You've heard about carfentanil and other things that are even more powerful. Basically, I think the usual measure is a kilo of pure fentanyl, that is 2.2 pounds, can make 10 million non-lethal doses. Now, even in the world of hyper profitability of heroin, cocaine moved by the kilo, that is a enormous change in the market. You also see in the same Mexican cartels that are now receiving finished fentanyl and fentanyl precursors, largely from Chinese suppliers, the making also of methamphetamine. You now see reports of mixtures of these substances, even mixtures of fentanyl and other substances in counterfeit pills or in pills that are being sold illegally to fuel the market. That is a huge expansion of the profitability, and therefore the driving of the criminal enterprises that support this. Both report. I'm not in government anymore, so I don't see what the government knows. Although usually what the government knows is not exactly what when you watch television, it looks like it knows. But there obviously are Chinese criminal organizations that are moving some of this precursor of fentanyl into Mexico to be marketed by Mexican organized cartels. They are helping to money launder. They are helping to organize. They've tried to reorganize some of the cartels from some of the days of the warring between those cartels. Now, how many people are being harmed by this? Well, we don't know. We have a count of overdose deaths by the Centers for Disease Control that comes out roughly every year. But this is like looking at an epidemic by visiting cemeteries and doing a count once a year. We're not seeing where it's spreading. We're not measuring who's being affected. We're not measuring whether certain efforts to counter it are changing the dynamic of the epidemic or not. We are not treating this as a disease. When I was in office, I tried to get the Centers for Disease Control to begin monitoring this as if we really thought we were going to make a difference, as if we really wanted to make people aware of the danger and the proximity of that danger and the changes in that danger. The Centers for Disease Control, even though all the work at HHS funds talks about substance abuse as a disease, the Centers for Disease Control arbitrarily would not treat this as a disease. There was a previous outbreak of fentanyl poisoning in this country in the time I was in office, in roughly the 2006-2007 period. In retrospect, it was discovered that a chemist in Mexico produced what we thought ended up afterwards being about 1 kilo of fentanyl. It started killing people in the United States. DEA saw this first. We were hearing from medical examiners in Philadelphia, in Detroit, in Chicago, and we were trying to trace this because of the incredibly deadly nature of this, especially at that time. The very concentration of fentanyl makes it hard to dilute into non-lethal doses. So a kilo can be 10 million non-lethal doses if it's properly diluted. It's 500,000 lethal doses. So it's at the time we first encountered it, I contacted CDC and asked them to begin to work with these locales that were seeing it to begin reporting this in real time. I had worked in the Reagan administration, as Bill said, during the AIDS epidemic, and we were working with education and with prevention tools at the start of that threat. And one of the things that that CDC did was it used its morbidity, mortality weekly report to report AIDS, HIV infections, and full-blown AIDS cases to maintain a proper appreciation of the magnitude of the danger and the harm being done. It won't do that with regard to substance abuse, despite the larger death toll that's currently being caused by fentanyl. Ended up in that earlier case, I ended up using the White House office to receive information on a weekly call from both law enforcement and healthcare professionals and coroner to begin to kind of try to isolate where this was coming from and to warn people and to stop it. You're not supposed to use White House offices like that, but since nobody else would do it, I felt we had a responsibility. So what you see today is an utter abandonment of what I believe is necessary sound policy, partly based on confusion, partly based on an argument about law enforcement and race, and substance abuse in particular with regard to law enforcement and race, and partly with regard to, I think, confusion about the nature and perniciousness of especially these drugs in taking over and taking away the freedom of individuals. So we have a kind of combination of forces that have led to the kind of confusion we see. I'll leave you with, and I'll be happy to take your questions, with one example. One of the places that's been on the cutting edge of the change in drug control policy is, of course, Portland, Oregon, where you may know recently they passed measures in Oregon, Measure 110, that was designed to decriminalize all drugs, not always the sale, but the possession. And the goal was that we're going to just simply allow you to receive a summons or a ticket, and you can, if you get one of these tickets for possession, you can call a hotline to get a assessment of whether or not you might need treatment. And if you do that assessment, you can vacate the $100 ticket. I have a friend who used to work with me who sent me, who lives in Portland, who said since the beginning of this year to through May, so the first 5 months of this year, 2,576 summonses have been given. Of those, only 116 individuals called the assessment line. Of those, only 24 even asked for treatment referral, and there's no information about whether any of them entered treatment or let alone finished treatment. Now, this is a very clear and I think obvious example of what we have here. When our people are in the throes of addiction, as alcohol or drugs puts them, they're not looking for help. In fact, they become angry many times when we have this myth about hitting bottom or choosing, but most people get forced into treatment by a family member, an employer. Many of them used to be forced into treatment by the criminal justice system and drug diversion courts that would supervise them. But that has been curtailed by COVID, and in many states it's not being pursued. So what we have on the street now are thousands and thousands of people in advanced stages of dependence, and in many cases with so-called co-occurring disorders, that is, with mental health problems that are also associated with the longer-term methamphetamine use, as well as cannabis use, as more and more of this data becomes visible and undeniable in the research community. So what we have is a massive substance abuse and mental health problem on our streets that's not going to be solved by 28-day treatment. Many cases, when I was in office speaking to drug court judges, they're talking about people, especially with methamphetamine, psychosis related to that. When you talk about opioid dependency, that dependency has relapse rates that are extremely high, even over long periods of times of sobriety. So we have created a kind of long-term problem that A, we're making bigger, not smaller, and B, we haven't begun to even calculate the cost of dealing with. We are not properly revealing to ourselves, to our communities, to the American people, what the magnitude of this threat is in loss of life, in loss of productivity, in healthcare costs, in education costs, in employment loss, in destroying communities and their futures. It's in the trillions of dollars easily, and it probably exceeds in most metropolitan areas all federal government benefits combined. So this is not just somebody else's problem, and the degree to which we've become indifferent to it and tolerate it, and the longer we do that, the harder it's going to be to put this together. Now, I could talk a little bit about what I think could be done, but why don't I let Bill ask questions you may have, and take some questions from those of you there.
Hi, John. You may not be very interesting talk. Thank you. You may not be able to see me, but I think you have experience with me shouting questions from the office next to yours and without seeing me. So I'll take a point of personal privilege and ask a few questions myself. I want to lead with a question about the reason for our policy community not mobilizing substantially on this epidemic. I mean, we have experience with COVID, and there was a mobilization. Some people would say even an over mobilization by public health authorities, and we're seeing smaller epidemics like monkeypox, for example, where public health authorities are rightly mobilizing. But there are 20,000 cases of monkeypox, probably only 2 deaths in the U.S. so far, and we have 100,000 overdose deaths for opioids. What is driving the fact that this is not resonating as a high-profile public health issue for people in Washington?
Well, I think 2 points. One is confusion and about what this is, and that removes the consensus about a priority. I used to also say, look, during the Obama administration, when it was dismantling efforts to control the drug threat, there was an outbreak of food poisoning from a food manufacturer, and the White House had statements. They immediately hunted down the source. They immediately, of course, stopped production, warned everybody. Compared to what was being done about drugs, it was a stark contrast. So partly also people have been told you can't do anything about it. If you try to do something about this, one, you are going to cause more harm by arrest, incarceration, using law enforcement, and it doesn't do any good. Now that stands in contrast to the fact that, in fact, there's few actual domestic problems that have been more susceptible to movement in the right direction when we do the right things, and the wrong direction when we do the wrong things. So it belies the actual history here. I mean, look, let me give you a starkest example. You will hear, as if it was, an a priori visible truth to everybody, that prohibition didn't work. Well, okay, we did have prohibition, and then we repealed prohibition. But it is true that during prohibition, the amount of drinking collapsed dramatically. The consequences, illnesses associated with alcoholism collapsed dramatically. What we decided as a people is that we wanted to drink. And so that law was changed. And we're in a democracy, and people, I mean, no one less a person than Abraham Lincoln, of course, gave a speech to a temperance association. The consequences were great. But what we have now is a policy community that believes you can't do anything, and if you try to do something, you're a racist. That our jails and prisons are full of young Black males who have been put there because they've had minor possession convictions, and they have been singled out by the policing in the areas where they live for undue and unharsh and unwise treatment by the criminal justice system. It doesn't make any difference that, that in fact, that's not who's in jail and prison today. People are there largely for violent and repeat offenses. In fact, drug crimes have gone down and continue to go down dramatically, not only in state systems that are the largest, but also in the federal system, where immigration violations are now, dwarfing anything else. And the other part of it is that the communities that are victimized are the communities where many times the people who are arrested live. That they're the places that call 911, has been said before. They're the ones who, you and I, when we were in office, sat in community meetings in places in Anacostia, in other parts of DC, in Boston, in Miami, in New York, in LA. And the people in those communities wanted to be kept safe. They didn't want to have generation after generation have to be dragged through addiction and the criminal justice system. They wanted it to be effective. And there was a failure to do that with sufficient rigor in many places. So it's understandable why there's this frustration. But the fact of the matter is, when you go after the sources of these drugs, you change the direction. And I think the other fact here is that I've even come to realize more directly, it's about supply. Fentanyl is a devastating killer because the manufacture and the ability to market it into the United States exploded. The same is happening with methamphetamine now from Mexico, as I said. And what's happening now, of course, is a great deal more, even uncounted addiction to cannabis and cannabis related psychological and health problems because we have exploded the availability of cannabis.
Well, let me follow up on that and ask. You seem to imply that the Obama administration carried on demand side efforts, right? Prevention, education, treatment programs, and seemed to discontinue supply. Talk about the effectiveness of the demand side initiatives when it was with respect to fentanyl. I know when we were in the White House, you had high regard for drug education programs and certain types of drug treatment programs that were effective. And so there was support for the demand side. How effective is the demand side on fentanyl?
It's not working at all. One, I don't think there's much being tried. Look, when I was last in office, the government of the United States had a $100 million advertising campaign to discourage teens from using drugs, especially marijuana. But we did a variety of things, including even steroids. And it was used the most sophisticated advertising to target that audience. And we had declines. You know, if someone told you they were able to make a 25% decline in drug use today, that would be considered completely impossible. But we've stopped trying, and the result has been an increase in use. There is no ad campaign. The president of the United States, Joe Biden, had a great record in the Senate working on the drug problem, and he's walked away from it. His own drug policy office. I mean, what is the policy to stop the fentanyl epidemic? We have completely irresponsible government posturing on a variety of other issues, and ignoring the drug use. I mean, what Obama was going to do is, you pass Obamacare, there'll be treatment for everybody. But treatment's not the problem. You have to stop the poison. This is better understood as a mass poisoning than it is as an issue where you can treat your way out of it. Yes, of course, I believe in treatment. I've sent family members to treatment. I've helped friends get family members into treatment. And in fact, the criminal justice system was revised to use treatment and other kinds of either mental health services to take people who are come into the criminal justice system because their lives are so out of control, but to help them get at the root causes of those things through helping them with their substance abuse problems, their mental health problems, even their educational problems. So we've tried to now say we can't do much about this. There's no press on any of those initiatives, and we can't expect those initiatives to work when we're flooding the country in a way that we have no systematic effort to stop with these poisons. It's not being tracked. It's not being measured. Other countries in the world use wastewater testing to test the metabolites of various substances. We experimented with this when I was in George W. Bush administration. The government did not follow through on that. EPA wasn't interested in that. You may know from your health work, HHS and EPA do a variety of testing to test water for hormones, other substances that can be poisonous. We do it for counterterror to make sure things aren't put in drinking water and runoff. But we don't test, and we could test for substances. Now, that wouldn't give you exactly an account of how many people, but over time, you'd see trends of increase or decrease. You would know whether demand and supply efforts are working or whether there's an acute crisis that you have to warn people. You don't see any conviction by political leaders, and frankly, by many intellectual leaders, to say we have to do a better job here. They've thrown up their hands. And let me just say one other thing while I'm being too long-winded here. The typical argument here is you can't stop supply, that either it's too much of a distributed phenomenon, or that the demand is so extreme that there will be a way of stimulating supply no matter what you do. One that's, again, not consistent with our experience of these things over a significant period of history. But the other is, Let me take an example from 9/11. At 9/11, we learned that a small number of terrorists can do mass damage to the United States. And we committed the United States to stopping such a threat anywhere on the globe. And the fact that you haven't had another Boston bomber, another attack on the Pentagon or New York City is a measure of how effective we can be when we use the tools of intelligence, law enforcement, and military force to stop them. This is a massively more destructive phenomenon guided by the Communist Party of China through these criminal proxies and through their own pharmaceutical industry. And we're not stopping it. That it's not true we can't stop it. It's not true that we can, and again, I'm not saying you can go to zero. It's not an on-off switch, but I am saying that this requires a retailing to millions of Americans and the money laundering of billions and billions of dollars. To suggest that we are not able to do that when you have the example of what we've done with terror and what we're doing in other areas is ludicrous. But it's the excuse of people who either have a misguided understanding of the phenomenon or who don't want to be held responsible for the performance of their own agencies or the public trust that's been given to them.
Well, let me follow up on that and maybe go the distance. So, since the United States has been in combat for 20 years, and arguably we have the most formidable U.S. Special Forces in the world, should we be deploying them in Mexico to take out the labs that are producing this stuff with Chinese chemicals? I mean, is that a policy option that should be considered?
I would attack this at every stage along the way, because no one point of attack is going to be completely successful. One, I would put pressure on the Chinese themselves. They will resist this because they want us to be destroyed by this. I mean, their typical response, I dealt with them in regard to meth precursors at the end of the George W. Bush administration, when they were sending pseudoephedrine into Mexico for the making of meth after we closed down many of the small toxic lab production that was killing so many Americans through regulation. And they'll play games about, oh, we don't know, oh, we can't find it. You have to find something that they care about, and you have to put it at risk. And then all of a sudden, oh, we found two guys, you're right, and we executed them last week, so you can't question them. We have to not let them get away with playing that game. They run a state that can find somebody who advocates democracy and take them out. They can find people who are making this. They're allowing it to happen. There's evidence that there even are preferred individuals in the regime relationships that are allowed to move money out of China through financing loads of precursors and drugs through the criminal organizations into Mexico. So this is a deep level of corruption, as well as an intentional effort to do harm to the United States. So I would first start with China, and I'd be careful, because if we let this continue, we're not aggressive enough. The other great producer of pharmaceutical materials that could be used here is India. They don't have the same kind of control, and that will be a more difficult problem. We ought to be prepared for that. Secondly, in regard to Mexico, look, when I was in office, we had a growing and more effective relationship with the Mexican government. We were helping to train people. We were sharing intelligence. We were working more on enforcement across the border. We had a different president. President Calderon is in my experience, unique as a Mexican president. But we also can tell them that we will not allow things to happen that they want to happen. They want a variety of things from the United States, not only trade, but remittances and other things. There's a variety of ways in which we can, short of direct military kinetic strikes that are necessary. But I will point out that at some level, the president of the United States' responsibility is to protect the people of the United States, and the Mexican government can face the responsibility for either stopping production and trafficking and the individual's use of chemicals and shipment routes and money laundering, or it can be these things can be put at risk through our means unilaterally. We worked with the Colombians when I was in office. We dropped the availability of cocaine in the United States measured by a variety of factors, including workplace drug testing, by 60%, working with President Calderon to help not only with eradication, but with the destruction of the left and right wing criminal organizations that were trafficking. We took the gloves off. We used direct action with the support of the Colombians, and we also had a president there who extradited hundreds of individuals who were indicted in the United States out of his country here. That's a very difficult thing. Most governments won't do it, but they did not have the capacity to hold these dangerous individuals in their prisons. So we indicted them, we took them, and we convicted them and held them. Some, of course, still today. So we have a variety of tools at our disposal to start, and we don't have to immediately, send in the predators. But the fact of the matter is, what you need to see first is determination. Secondly, you have to go and you have to give options for doing the right thing. The other thing you have in these countries is when you let these criminal organizations become too powerful, the way they reduce risk is to compromise law enforcement, security forces, and political forces. Whether those individuals are completely owned by these criminal organizations or simply intimidated until they're given a situation where they can do the right thing without committing suicide. We have to remember that. I've worked with people in some of these countries that are quite brave. They don't have the situation that we have in our country to stand up against terror and violence. But make no mistake, with the amount of money that's going to these groups and the ruthlessness with which they can conduct themselves, it is not easy for these individuals. And you have to think about how you're going to take apart those threats, which we can do and have done in the past, and make it possible to succeed.
Yeah, well, it sounds as if federal policy is in a bit of disarray for currently. So let me turn to Massachusetts, which is ground zero for fentanyl in New England. It's huge seizures are happening. Last year, overdose deaths, I think, were up close to 9% in Massachusetts. So if the feds can't really get their act together for the near term, what would you recommend for strategies for state level policymakers? Is there anything states can do that would make a difference?
Yeah, well, look, first, I think I would start collecting and analyzing information as if you intended to make a difference. How many people are overdosing not a year ago, but yesterday and today? How many people are coming into emergency rooms with overdoses or drug-related problems? The biggest single factor predicting an overdose death is a previous overdose occurrence. What are we doing to wrap health services around those individuals and their families when they get into trouble and they show they have an abuse problem? What are we doing to deal with the people who are obviously in the throes of substance abuse and mental health problems, laying on the street? You don't have to, it isn't finding a needle in the haystack. They're laying in front of you. You have to turn away to not see this. And we have become a callous community and a callous nation in the face of the bad policy that we're now following. Now, make no mistake, it's going to take some time, and you certainly do not have the capacity to treat all of these individuals at once. But the best way, to show you how out of sync we are with what has worked in the past, the best way to do this with people who are passed out on the street is violate them for possession, put them into a drug court or diversion program where they will be given supervised treatment, drug testing, and services for a range of conditions that many of them have, and then prepare to do that over a longer period of time. Because many of these people are highly involved, and they're not going to be adequately treated, and their lives are not going to be turned around by a 28-day program or even a 2 or 3 month program. So you're going to have to create levels of capacity. But first and foremost, you have to stop the fentanyl. You have to treat this as a poisoning. And therefore, you've got to begin to break down the organizations that this is coming from. It's more difficult to do it in a jurisdiction that's surrounded by other sources and other trafficking networks. But most of the time, when you take out a trafficking network in a neighborhood, in a sub part of a community, in a county, in a state, it doesn't immediately reform. And if you then could put more resources on the lesser extent of the effort of trafficking groups to come back in. So what you have to do here is you have to collect intelligence. You have to make that intelligence real time, and you have to have a strategic picture. No state I'm aware of, and certainly not the federal government, is creating a strategic picture in real time of what's happening. That's what we're doing for terror. We track threats in real time all the time, and we lay them out on a map, and we lay them out on over top of the jurisdictions responsible. We are not, until we behave like we would if we wanted to make a difference, we're not going to make a difference. I mean, that's just simple. That's about as simple as it gets in the policy world. We're not taking this. If this was the spread of Ebola, think about what we did in response to that. Small number of cases, we spent millions of dollars, we tracked it everywhere we could, and we prevented it from becoming a widespread epidemic. It's more widespread. It's going to take a longer time to shrink this down. But if you're in Massachusetts, you've got to start finding where's the poison coming from, stop it in an effective way, that is, violate these people immediately, and begin to pull this off the street. I'm less concerned, frankly, about the length of sentences or the measuring of some of the charges that could be. What you want to do is treat this as an active danger, and remove, like, an active shooter situation. I need to take this poisoner out of the picture to save the lives of the people that are coming to. I'd also go to the people that may be then going into withdrawal and say, and aggressively go on the street and we'll try to bring them into treatment. But we have tools to do this. It takes, one, determination, and two, it takes political leadership that tells people we're not going to continue to watch people suffer and die who don't have to suffer and die.
Thanks. I'm going to open it up to audience questions. If you want to queue behind the microphones, there are two microphones where John will be able to hear your questions. We can start, I'll alternate back and forth. But if you do have a question, you'll have to speak into the microphone, because John will not be able to hear you if you're just in the audience. So why don't we start here?
Hi, John. It's Ruth Madras. Thank you very much for an excellent talk. There are two questions. One is the culture of the United States. The most recent MTF and the NISDA data show that young people who are Asian Americans use drugs at 1/4 the amount as Caucasians and as African Americans do. And I think that's one area where we have done no studies whatsoever in trying to understand why those cultural differences make a difference with regard to youth drug use. And I think that's really a critical point in stopping the pipeline. The other issue that I'd like to hear your comments on is the concept of the opioid crisis, which was catalyzed by prescription opioids. And the reason I bring this up is that it's an exactly beautiful example of supply feeding an increased number of users and an increased number of people with opioid use disorder. And yet that is always dismissed by the modern convention that all it did was give rise to fentanyl. And I think that's an issue that should be raised as an example of, if you don't cut supply or if you increase supply, you end up with a national catastrophe.
Yeah, I think that was Bertha Mondras, wasn't it? I thought I recognized her voice in my former colleague. Let me start with the first one. what happened with OxyContin and prescription opioids, of course, was an irresponsible use of data to suggest that these powerful substances could be distributed widely without supervision. And then Purdue Pharma, there's been books about this, took over and drove that into many communities in a way that should have been stopped earlier on. The FDA didn't do its job. I talked to the FDA about this when I was in office many times, and their argument was, well, we only approve drugs that are safe and effective when used as directed. They said, this is a drug, this is a substance that is prone to not be used as directed. You must have other safety measures. America's paid a horrible price for these institutional failures. And now when we began then to do things like, hold Purdue Pharma accountable, and we charged them and fined them when I was in office, and they've been charged and fined again subsequently. You began to see the pharmaceutical industry forced to take more responsible action. I'm not sure it's exactly where it needs to be yet. But the fact of the matter is the destruction from prescription opioids has gone down because the supply has gone down, as you said. There was some effort claim that, well, once people got those people who got addicted through medical procedures and the use of prescription opioids in connection with those procedures, that fueled fentanyl and heroin. Well, there were some people who used fentanyl and heroin after using prescription opioids, but there also were a lot more people who used fentanyl and heroin because it was more available and because they were they first experimented or played with it and then couldn't stop. So it's a combination of factors here, and I don't think we've done as good a job even still with the diversion of prescription pharmaceuticals. There's always like, well, we don't want to harm legitimate medicine, and nobody wants to do that. But the fact of the matter is, if you go to treatment centers and you have you have people who were addicted to prescription medications, once you become addicted, the quantities you need are not going to be dispensed by most legitimate physicians. You've got to find a pill mill. You've got to find somebody who's responsible. And law enforcement, for some reason, has resisted talking to the victims in these settings. And frankly, the people I met who were running treatment centers, I would ask, why don't you convey this information to law enforcement in your area? Clearly, the people who are in these centers are not trying to get anonymity. They hate the people who've addicted them. So we have a serious problem in using the information we have across these lines. The other question you ask about kind of the different levels of dependency and use among different ethnic backgrounds, that's a clear pattern in some of the data. I would say that it's complicated to tease that one, as you know, because some of these substances have different effects on different genetic backgrounds. So there can be a factor with some of that. I'm not qualified to make all those judgments. But the other part is that there's different patterns of family supervision, and frankly, we're not all supposed to hate stigma, but of course, stigma was one of the ways that people learned to restrain themselves. That is, they didn't want to have the shame of doing something that their family and their community would find reprehensible. I think there's bad stigma, but there's also good stigma. So I'm not somebody who thinks we get rid of stigma. So I do think we have not done a good job of telling people these substances are dangerous. They're presented as attractive. The way it comes to young people is somebody who's using and says, hey, I use it, doesn't hurt me. So it's presented as something harmless. It's presented as something that's a rite of passage, experimenting with these dangerous substances. Or, hey, you're anxious, you can try this. Or, hey, you're used to using other stuff. Most people I've met in treatment centers for opioids, they almost all started with cannabis. Or you're already drinking, why not try some pills? Or why don't you try some? So the problem here is that the initial contact with these substances is not like your initial contact with a can of Drano with a skull and crossbones on it. It's seductive. My friends are doing it. It's something that people I want to seem like are doing. And so it's overwhelming. And that's when we talk about what do you do about prevention today. It's overwhelming the message everybody's getting. If you watch the 11 o'clock news in most metropolitan areas, you're going to hear about another overdose deaths locally or from some celebrity, if not every day, several times a week. I don't have a stronger prevention message than that. If you take this, you can die, you will die. So I think what you have to face the fact that this is fundamentally about supply. Yes, when you want to get people into treatment, but the way to encourage successful treatment is to remove the access to the substance that has to be taken to keep people sick. So that's the point of drug testing and treatment. That's the point of pulling people out of friends and circles of people that encourage destructive behavior. So we don't want to think about this as a supply thing. We want somebody to have a epiphany. Not going to happen because of the way these substances work on the brain. And frankly, what we also have to face here is, despite the ethnic differences referred to, every single one of us can be addicted. It's just taking any of these substances long enough, and you will become addicted. That's how we can addict monkeys and rats and mice, because they have the same susceptibility. So this whole thing about, well, people are gonna have a kind of a rebirth of responsibility is just silly. And we need to help in ways that are really measured against whether or not they're effective.
Why don't we take one from this side?
My name is Avi Nelson. Thank you for the talk. Two questions. One, how much of the problem here is because of the porous border? We hear stories about the illegal immigrants bringing it in large amounts. The second is, you mentioned cannabis a couple of times, and just recently you implied it was a gateway drug. How do we balance the two forces here? There will be some people who will take cannabis like they take alcohol and will never deteriorate, go further, and become a problem. There are others who take alcohol, become alcoholics, or I guess will take cannabis. I assume cannabis leads to the use of fentanyl. But it seems to me there has to be a balance here between the rights of the people who are exercising sort of adult discretion and those who are going to, by their own hand, go into a period or an area of deep despair and maybe worse.
And John, we have a few more audience questions we want to get to. So if you could keep it a little briefer, we'll get through the whole audience.
My apologies.
Not at all.
The porous border doesn't help, but to really stop the movement across the border, you have to have intelligence that looks in from where it's coming from and to where it's going to. We are not doing a systematic job, obviously, but fundamentally, we're not gathering the intelligence to be able to stop it at the border. Fentanyl is very concentrated, particularly hard to stop. On the cannabis question, I think the science all goes in the other direction. There is no safe use of cannabis. And in fact, there was a recent article in the Wall Street Journal. You saw some of the research is showing that 1 in 20 of the people using cannabis, especially the more potent varieties that commercialization has produced, are now having serious mental problems. The argument was, well, it could be used like anything else. First of all, yes, you can socially drink. That is, you can drink without becoming intoxicated. There's abuse in that, and people are not candid with themselves, and they can be fooled by the use. However, cannabis and all drugs of abuse, every use is an intoxication experience. That itself increases the risk of dependency and addiction. Secondly, the view that cannabis is tolerable, I think, is going to be belied by the damage it's doing, but we're not looking at, because it's fashionable to say, well, we have a social tolerance, and we should have a social tolerance. I know science has kind of discredited itself in a lot of ways, especially during the time of COVID and making claims that are black and white when science is always provisional and more complicated. But we should go by the science. The FDA ought to provide in the same standards of safety for things like so-called medical marijuana, which it does not do, as it does for other pharmaceuticals. It should look at other these products for safety. They won't stand up to it, and you will see the harm. This is a willful blindness that is letting people think that it's harmless, and it's not. I mean, I don't know what Boston's like, but Washington, New York, other places, there are a lot of people on the street, semi-functional, who are smoking cannabis as they walk along. That is not even being seriously examined.
All right. A gentleman I talked to during the reception, he's an emergency room physician, so he might have some interesting things to say. We'll turn to his question.
Hi, Mr. Walters. My name is Mike Tosa. I'm a emergency physician at Boston Children's and then also a medical toxicologist here in Boston. First off, thank you for your humility and humanity in talking about this. It's such an important issue. The issue that I really wanted your opinion on came down to the treatment options that we have. So we do have very effective pharmacologic treatment in terms of buprenorphine and methadone, and then life-saving at the time of overdose with naloxone. But there's significant restrictions on our ability to prescribe buprenorphine. Providers have to have their X waiver, and then in order to get methadone, people have to go to methadone clinics. Some people can get take home, but typically it's to the clinic every day. And then naloxone still requires a prescription. Every state has a standing prescription, but there's still significant barriers, particularly with youth accessing it. So I was just curious about your thoughts about what can be done to easy availability of treatment options to people with opioid use disorder.
Yeah, I think the one of the problems here is that we've had a kind of unscientific dogma about we have a treatment option, we sell the treatment option, and then it has to be everywhere and it has to just be released. That in many cases these treatments have to be guided by a medical professional, and there needs to be more involvement with that individual. In some cases, we can make it more convenient to use medical assisted or pharmaceutically assisted treatment, but it's also we also don't want to end up where we were with synthetic opioids in medicine, where, hey, we'll give this to you, go away, don't bother me about this. We need to make sure that we continue to have, I think, careful assessment of what kinds of methodologies work, where they work, what the profile of the individual that we're using these methodologies on, because especially, as you know, certainly you have many more people with co-occurring disorders who are self-medicating for reasons of mental illness or other mental conditions. So you want to make sure that you're not in one way kind of treating one thing, but it's not an adequate center of gravity for what you want to produce with the change. I certainly, when I was in office, we supported expansion. We got expansion of methadone treatment. We got expansion of buprenorphine. There's been a lot of talk about the promise of some of these substances, but also I will say, and I'm not saying you're involved in this, but there also were places that kind of wanted to have something to give to people to kind of pass them through the system. That's not a motive without some suspicion, in my experience.
Okay, John, we're going to take one more and then let you get back to your family. Sir, go ahead.
All right, thanks. Thank you, John, for your insight on this issue. My question relates to addressing this at the source. As you've mentioned, the Communist Chinese are pushing this, and we seem unwilling to confront them on this issue. We're on other geopolitical issues like Taiwan. We're taking a very militant stance. So I'm interested, it seems as if this is some sort of chip that we're throwing away in the great game, where we're going to give them this in order to take a hard line somewhere else. And if you could comment on that, why it is that we're not willing to address this with them during this administration and kind of at this time.
Well, I think it's insane to give them 100,000 lives a year and climbing. I mean, that's just that's a fundamental failure of American political leadership to protect the country. Look, there's a lot of things we can do create pressure points on the communist Chinese. I mean, we can go after individuals there that we can produce if we focus intelligence resources on individuals who are colluding, and it's government officials that are colluding, and go after wealth, access, travel, other things. We can go after, look, you're sitting at Harvard. We can put pressure on student visas as we have, and we can be selective about it. We can go after the export of U.S. capital to support Chinese needs at various points in time. We can go after, as we have in other areas, we can go after the import of critical elements. We can, as has been threatened before on other matters, we can start delisting Chinese companies who haven't complied with regular SEC filings anyway. Again, I don't think this has to be and it shouldn't be a single tool. What you want to do is begin to take apart the freedom with which this poison gets to be shipped to the United States. Now, they are using criminal proxies, so they have a cutout. That is, they can say, oh, well, that was this group here. I think we have to be very determined in saying, stop the fentanyl, and we know you'll stop it when the dying here stops. So don't play games with us and say 1, 2 groups and we have to chase. Well, wait a minute, it's not that. It's not. I would not argue with them. I would start applying pressure, and I would use asymmetrical pressure. I would put pressure on other parts of things that they care about, as I say. And if I can find connected people who want to travel to the United States, I'd cut off their visas. We used some of that actually in Latin America with some effect. It was surprising to me how far it went. But there's a lot of other things that they need capital for, especially now. They need oil. They have an energy problem. They have a food problem right now because of a drought there. Again, we're not thinking about this as a, let's use all the tools that we have on the table. The Chinese are vulnerable, and we let them be less vulnerable by not taking advantage of opportunities.
John, our deepest thanks. Thanks to the audience.
I'm sorry I'm not there with you. I really do wish I could be there.
Okay, very interesting talk. Thank you for all coming out on a dreary night for a dreary subject, unfortunately. And I'm going to let Chuck Hewitt, whose family makes these programs possible, close the evening.
John, Bill, wow, this is pretty tough stuff. Thank you for so candidly and directly addressing this subject, which is strangling our medical healthcare system in a fundamental way, standing in the way of everything else we're trying to do. So it really does require the kind of attention you're talking about tonight. And thank all of you for attending this evening. I was reminded during the day of mourning for her of Queen Elizabeth's inspiring comments during the height of COVID. We can take comfort that better days are ahead. We will be with friends again. We will be with families again. We will meet again. This evening is one of the first steps by Pioneer Institute to reinstate meetings on important policy subjects faced by our country and state and studied by Pioneer. So thank you for being part of that. John's incredible depth of knowledge and experience with the fentanyl crisis shines a bright light on the issues that need to be addressed. This event is very special to our family as it celebrates the life and work of our dad, Colby Hewitt Jr. Dad felt blessed to live in Boston with its world-class leadership in medical care, research, and education. These lectures were established by Pioneer and Beth Israel Deaconess, both institutions he served as chairman of the board, and has been continued since by Pioneer, supported by donations from friends like all of you. Well, fentanyl is relatively new to me, at least. Almost 10 years ago, the subject of this lecture was substance abuse and the public-private response to handling it. It is discouraging that a decade on, it remains a fundamental medical and public policy crisis. It is, however, encouraging that there are folks on the front lines dedicated to seeking and developing solutions to it. Our entire medical establishment is dealing with the reality that behavioral health, mental health, and substance abuse is straining the system by the huge dedication of resources and effort required to handle its demands. Clear understanding of the issues, as we've heard tonight, is fundamental to work through this, and that is what Pioneer does. As our founding chairman, Pete Peters, always admonished us at this point, at the end of an evening, if what you've experienced tonight stimulates a generous impulse towards Pioneer, please act on it. On behalf of all of us at Pioneer, thank you and good night.